I'm going to hand us over to Dennis, who's going to talk a bit about kind of what's going on nationally to support some of this capturing of information that you can kind of see North East London and Barnet have already kind of been doing, and then linking in with the national minimum data set. So yeah, I'll hand over to Dennis to say more about that. Thank you.
Thanks very much indeed, Jenny, and good afternoon, everybody. If I can have my first, on to the next slide, please. Yeah, I've been fortunate to have worked on this project now for about 3 years, working to help develop the minimum data set, which has then also been turned into an information standard. In fact, some of my colleagues on this, Jeremy Wilkins has just left, I noticed, but I've got Alison Green, Angel, and also Jules Ford, who has also worked on this, is also on the call. So that's good to be able to have that support as well. So yeah, this has been a really interesting journey. So for the last 3 years, we've been trying to develop a minimum data set and a social prescribing information standard to get the consistency across the country of all the stuff that you've been talking about. It's been really great to be able to be hearing what the other presenters have said, and we've been working with North East London and also with Caitlin, amongst many others, to, I suppose, inform this particular journey. And so the information standard is all about recording and sharing consistent information within social prescribing. And you know, it's certainly there to be able to support the conversations between the link worker and the client. It's there to be able to show people that the healthcare is joined up, and really importantly, I know it's been mentioned 2 or 3 times today, that people don't have to retell their story multiple times. You know, it's really paramount that people can only need to tell their story once. Providing information that can be shared with the people themselves, their families, or their carers. And again, it's been stressed, how do we get that information back to the referrer and to the GP, not just for the person's overall record, but also to, I suppose, and we'll talk a little bit more about that later on in this session, about actually improving the quality of referrals as well. And again, it's been said a number of times, it's critical for commissioning that commissioners understand what is happening out there, and helps, I suppose, understand the scale and effectiveness of social prescribing services. You've been talking about that locally, but nationally, and as Jenny said at the beginning, social prescribers have been on a journey. They've been out there. I've worked with a number of GPs throughout the country, and there are still loads and loads of GPs that don't really understand what social prescribers do. They don't actually understand what referrals they should be making to them. And I think it is a national issue that we need to be able to get some form of consistent data back so that there is a national understanding of the value of social prescribing. And I have to say, you know, the team that we've been working with, this has been an absolute crusade over the last 3 years to be able to really put this front of mind and foremost. And so the Professional Records Standards Body, PRSB, have developed the information standard working with the team. And so that is now a standard that software providers and other people they have to commit to be able to commit to that and to meet to that standard. And so there is a formal standard out there around information and that includes the minimum data set. So yeah. So what does this actually, you know, why was it created? Well, I think it's been created for all the reasons that we've just talked about. We've had inconsistent and perhaps no information out there. And the fact that a number of care providers haven't necessarily had the information available or been able to record it or know what to be able to record. And it's making sure, I suppose, that the right professionals get the information at the right time so that it can be used to inform decisions about the care of the individual. And it's also making sure that information is tailored for different needs and making sure that, I suppose, that they get the totality of the information. One of the things that I suppose that we've seen, certainly through this process, that when somebody is referred, the rationale for referral very often is very different to the actual need that they've received or they've actually got, and therefore the support they're subsequently offered is very different as well. So again, it's being able to get that information back so there is a consistency and an approach to ensure that, I suppose, the whole loop, if you like, of the whole process is joined up. So that's why the information standard is being created. Sorry, if I can have the next slide, please. And a subset of the information standard is the minimum data set. And this is only something like 78 terms, which have all got SNOMED codes so that they can be coded, whether it's on EMIS System 1 or anything else. And they're broken down into three major components, which is the demographic information around the initial referral on the individual, the needs and concerns that that person's got, the support that's subsequently being offered. And we've talked a lot about ONS4 and various other things that are part of the review, if you like, on this particular call. And that's part of the measures. But the measures, we are not dictating, if you like. None of this is actually dictated. None of this is mandatory. It is, I suppose, it's best practice, but it's not mandatory. But there are 78 terms, and they're broken down into those various different component areas. And they are now, I'm really thrilled to say, they're all available on the various GPIT systems. And Lauren's been really good and really helpful the last few months of pointing out where it isn't on EMIS, where it should be. And it's been great that we've actually got those there. We've also been working with we've also mentioned Joy and Elemental in particular on this particular call. We've worked with them all the way through this. They're fully aware of it. And there are a number of other social prescribing software providers that have also signed up to that, and that should be on their systems now. But one of the issues is that we know that not every link worker has access to systems. So hopefully we are, we would hope that Ardens, and I think it is already on, Ardens have signed up to be able to create templates for that. But because these are only 78 terms and they're very high level, recognize that actually it may be possible to be able to collect these on Excel spreadsheets if you have nothing else to be able to do it. So it is available on the systems, it is available on templates, but also if you could create, if necessary, your own Excel spreadsheets to be able to do that. So one of the things people say, well, obviously this code isn't quite what I wanted it to be. Well, these are very high level codes. And when I look at the templates that have been shown earlier on, there's a lot more information that goes over these. So if one imagine these are headers rather than detailed analysis of various different needs, and recognizing that every local area will have their own needs, it's going to be imperative that you still collect what you need to collect locally, but nationally we've got a series of high level terms so that they can be brought together and they can be considered. And this is the beginning. So the aim is also to add to the data set in time following experience of the rollout. So we can have the next slide, please. So again, we've talked about why we're doing this really. I mean, again, commissioners having a better understanding of the needs and support required of the locality to ensure they're providing the right support, the right financing. And again, looking at rollout of population health management, integrated neighbourhood teams. A lot of the work is using social prescribing link workers. One of the challenges is about the data that's getting back, and a lot of initial population health management work never got the data back again from social prescribers to be able to really understand what was happening. So from a commissioner's point of view, and this is where we talked about the VCSE sector being able to collect data and be able to feed that data back. We have to be able to provide that sort of link to enable them to be able to do that, because again, hopefully that will then show the demand and also the opportunity available to be able to support that demand. And again, talking with various different voluntary sector organisations around the country doing this project, a number of people said, well, actually, we've got the capacity to be able to deliver this, but nobody ever asked us for it. So again, it's trying to pull all that together. So again, it's looking at supporting clinicians, it's clinical referrals, it's supporting the link workers by demonstrating the benefits of their work. And again, so many link workers I've spoken to have said that people really don't understand what I do. We don't have a consistent way of being able to feed back. I mean, we've heard some wonderful best practice here, but a lot of people are actually feeding back on case studies, or it's verbal, or they're not feeding back at all. So again, it's trying to get at least the bare minimum of feedback at a consistent approach. Sorry, I know you moved the slide on. Let's go on to the next one now. Thank you. So again, not everybody will be 100% happy that these terms are absolutely perfect for them. The difficulty is we are never going to get to a point where we end up with a relatively low level number of terms that are going to mean everything to everybody. And we have really worked so hard with so many different stakeholders, including a lot of people on this call, and imperative that we work with people with lived experience, link workers, business managers, regional teams, researchers and academics and other social prescribing professionals to try and get as much input as possible. And we've done 2 different pilots to be able to test it, and we've taken the feedback from that as well. Equally, we've worked with software suppliers and tried to encourage them and ensure that they're able to manage this. And they've also looked at existing SNOMED codes, because each of the terms that we are providing has a SNOMED code. So if you're looking at it on the system, as one of the contributors said earlier on, you don't need to worry about the code. It's just behind the header. So again, we tried to look for existing SNOMED codes, so we haven't tried to duplicate lots of other ones where we don't have to, but equally we've had to develop some new ones because some just don't exist. And I think, again, one of the elements of this is trying to demedicalize the terms for social prescribing, and that was what a major bit of feedback that we got from the groups as we were trying to do this, that so many of the terms were very, very medical, and so the terms we've got within the minimum data set now are much less so and much more general. And hopefully, again, that will no doubt develop as time goes by. So I'm very conscious of time. So next slide, please. So basically, the question I'm sure people are asking, so what does it mean for a link worker? Well, I think, again, some of the contributors earlier on that were actually using Lauren's templates are already talking about it. So basically, if you're using a GPIT system or social prescribing software, it should be relatively simple. The code should be there, and it should, I suppose, work in the way that you do it. But it does mean that you may have to structure your approach differently to enable you to be able to collect the information. But I think the aim is to try to engage it as you do your work, rather than sort of trying to create a whole load of tick boxes that you've got to do, because that's not going to work for anybody. And we are hoping that data managers will, like Lauren, will be working with you to ensure that they find the best ways of you being able to achieve this in your workplace. And if you haven't got access to a software system, again, it's how we can perhaps help you, support you collect that data on a spreadsheet. And again, hopefully it should make providing feedback on referrals much easier. And again, as I think we've heard before, that feedback mechanism is absolutely crucial. And also hopefully reduce the need for lengthy case studies or examples, so that it's actually factual and rather than quantitative rather than qualitative. If I've got that the right way around, I always get confused with those two. Next slide, please. So the standard is now finalized and published. The data, you can collect the data as soon as you want to go ahead in your local area. We will be doing a soft launch in January, and there's a range of support materials being put together. There's an overall sort of backing document called Why Data Matters. We're hoping that's going to be available on futures. And also the Keeping Records and Measuring Impact e-learning module for social prescribers is currently being updated. And I know Alison's on the call now. She's been working to help produce a helpful video, which is being done in the London area to reflect the changes. And again, it's trying to ensure that we get the message across to GPs and others around this and how vital this is. But as I said already, this is the first iteration of the terms, and they are very high level, and they're probably, as I say, not as comprehensive as you collect already. So they will be reviewed on a regular basis, and inevitably there will be changes. But I think, as Victoria said earlier on, this is the beginning of a journey. This is not the end, and I think this is the first step nationally to try and standardise data and standardise the collection of data. So sorry, it's a bit of a run through. Sort of conscious with time. It can be a bit wordy. So anyway, that's me done, and I hope to see some people in the breakout room afterwards.
Thanks, Dennis. Just before we kind of move to the breakouts, I wanted to ask kind of what, obviously there's all this stuff coming out in January that can support people and thinking about how they can embed this into their practice. What can people do now to kind of prepare for that?
That's a very good question. We will be looking to, I suppose, actually, I mean, I've got the terms that we've got. I'm happy to be able to share those with anybody that wants to be able to do that. I think it's for those that are not collecting data in a consistent way, is to be able to have conversations with their business teams or their commissioners or whatever else it is to start the ball rolling and say, this is coming, this is an opportunity to be able to do this. How might we do this collectively? And again, when we started the implementation part of the project, we do need to be able to speak to commissioners, we need to speak to PCM business managers as well as link workers to be able to get everybody joined up to recognise what the opportunity is and how they might work collectively together. But again, just just be aware, I think, that this is coming out, and perhaps start those conversations.
Amazing, thank you. Yeah, I think that's important to kind of flag that it's not just an opportunity for social prescribing services to capture their impact, it's an opportunity for commissioners to get the data they need to make decisions. It's an opportunity for primary care to understand how to work better with social prescribing services. So yeah, bringing all those people around a table to kind of discuss this is important.